Welcome to CDP's podcast, Practical for Your Practice,
where we give you actionable intel to support what you do, one colleague to another.
Welcome everyone to Practical for Your Practice, where we practically talk about practice each and every episode. Carin Lefkowitz is here with me today. How's it going, Carin?
It's going great. How are you, Jenna?
It's Monday. You know, it might not be Monday when you're listening to this, but it's Monday when we're recording it.
It's
Monday
a very
has
Monday,
a
actually.
Monday. Yeah,
Yeah.
it definitely doesn't feel like a Wednesday Monday. It's like a
No.
Monday.
Mm-hmm.
Yeah, lots going on. And you know, we have talked about this topic in a past episode, but it's one that never gets old and doesn't really go away for most of us providers. It's a topic we don't necessarily ask about, but a really important topic to address. Do you have any guesses as to what it is, Carin?
Oh, too many, and probably some that would get me into trouble. So, I won't
Kind of
venture a guess.
painful. Your answer's painful.
Is it paining you
It's
inside? Is it a
paining me.
chronic pain that you're
You tend to
experiencing?
chronically pain me. I mean, yes, it's chronic pain. Today we are going to circle back and bring the topic of chronic pain back to the podcast. And I am super excited because our guest that we have today, I met in 2018, we just realized, which feels like forever ago.
Mm.
Pre-pandemic. That's how we always like time things, right? Pre-pandemic or post-pandemic. So this is a pre-pandemic colleague who was a part of our Forces for Health Wellness Wednesday webinar series. Say that fast 3 times. I would love to welcome the very fabulous Dr. Jennifer Murphy to the podcast. So welcome, Jen, to Practical for Your Practice.
Thank you so much for having me. I'm very excited to be here today.
Good. We're excited to have you. And just for our listeners, if you could give them a little background, a little intro of who you are and how you gravitated towards chronic pain.
I am a psychologist, clinical psychologist, and I really just kind of very early on in my career found my home in working with individuals with pain. And I feel fortunate that it happened. I wanted to work in a medical setting. And one of my first experiences was with individuals with pain. And I just really had a real connection with them. It was a group that I soon realized kind of felt underserved and misunderstood, I guess, in a lot of ways, and not heard a lot of times. And I'm just the person that I am. I kind of have that, like, want to advocate for people and want to root for the underdog and do what I can. And so I don't know. It just was a connection that ended up working well. And so I've worked with a specialty in pain for 20 years and a variety of settings, inpatient, outpatient. Most of my career has been in the VA, where most recently for the last 5 years, I served as the director of pain management nationally for the Department of Veterans Affairs. Before that, did a lot of, hands-on clinical work with individuals with chronic pain. And now I am doing a few different things, have my own consulting company, and recently joined Applied VR as a senior clinical strategist to kind of help work with them and explore some new ways to treat chronic pain and other mental health conditions. There's a lot of exciting things out there. So looking forward to the future and really feel fortunate for the past that I've had as well.
And an extensive past it has been.
I appreciated the description of chronic pain as maybe a condition that leads people to be unheard or dismissed in some ways. And that resonates with me quite a bit. But also, I'm thinking about how complicated it becomes when working with a military population. That experience of pain, what it means, it sort of carries additional meaning, I would imagine, in a military setting and different complications.
Yes, for sure. And, as we know, certainly veterans who receive treatment in VA, a lot of co-occurring conditions. So pain may or may not be related to the military. For some it is, for some it isn't. There's obviously hundreds of millions of people out there with chronic pain. But when you also have the context of the military, there may be PTSD, there may be, social considerations. It's just oftentimes very complex pictures for those who present. And there's a lot to kind of dig into and try to understand as far as the experience, particularly for military veterans and what their experiences have been. So it's a wonderful population, and it's perhaps an even more complex population as far as treatment goes than in the civilian sector.
Right.
And maybe even before, because I love military culture and I love all the influence of military culture, and definitely want to dig into that more. Before we kind of go there, even though, can we just talk about like what is chronic pain? Because I think a lot of providers get trained in assessing depression and anxiety and all the other things, but I think unfortunately there's not enough training in the assessment and treatment of chronic pain. So maybe can we just start the episode by talking about what is it, and why is it important to ask about?
Yes, absolutely. So a lot of times, in our culture, I think the way we think about pain is more acute pain. And acute and chronic, really, it's a timeline situation that separates those two. Acute is short term. It's typically, we look at something, maybe it's an injury or something that happens, and there's a healing process that occurs in 3 months or less is typically the timeline that we think of. You get something assessed, it's diagnosed, it's treated successfully, the pain goes away, healing occurs, yay, everybody's happy, moves on. And this is kind of how we think about what we want, right? This is what we want. We want to go to a doctor and ask them what's wrong, and they tell us, and then they tell us how to fix it, and it's fixed. The issue with chronic pain is that it is something that there may or may not be a clear origination point. There could be an injury, but the most important part is this is persistent pain or long-term pain. This is something that goes on for many months, and particularly in the veteran population. This is something we see people. It's not uncommon to treat a veteran who has had pain for 25 years. Mm-hmm. It's interesting sometimes when I talk to people, they'll be like, well, what if people have had pain for a year or two? It's more typical that you're seeing people who have had pain for 10 years, 15 years, 20 decades. But chronic pain is really anything that persists beyond that sort of typical either healing point, or again, doesn't come from a specific injury. Much of the pain that's out there is from the wear and tear of life. Frankly, a lot of these conditions that happen to all of us as we get older, back pain, neck pain, joint pain, we see this across the spectrum. So the important part about that is that chronic pain is pain that persists over time. And I think the most important thing really as far as messaging about pain is that pain is an experience. And really the way that we tend to approach it, again, is this sort of acute mindset, which is really this kind of Western biomedical, find it, fix it model. And the reality is that pain is very complicated, and it's impacted by so many different things that just understanding that and as a patient, understanding it that way, and for providers to talk about it and treat it that way is something that doesn't happen all the time, doesn't happen a lot of the time. And it's really an important part of sort of the misunderstanding, I think, of pain.
That's what I was going to reflect on, kind of your earlier comment about how misunderstood it is. I think we've come a long way But I think, what you're describing, this find it, fix it, providers want to find it, fix it. And when they can't find it, fix it, they get frustrated and they don't like knowing that they can't figure it out. And then, as a patient, you go and you want to have a solution or a thing to do. So I'm glad you took the time to really kind of draw that out, because I think it does explain some of the frustration that happens.
And I think taking out a step further, it's there's that pressure to understand it and to fix it on all sides, as Jenna said, provider and patient. But again, if I may, Jenna, bring it back to the military
Yes.
culture aspect of it, that goes, I think, even a step further of not folks generally don't want to be held back by anything, including physical pain. And I imagine might tend to sort of minimize it or manage it until they can't anymore. So it seems like it just probably becomes more and more intense and extreme and challenging to address at a certain point.
Right. And in the context of the military itself, there is, often this, I feel like Motrin comes up a lot.
Yeah.
Yes.
Kind of the push through, right? Like
Yeah.
you just sort of
Suck it up, buttercup.
absolutely. And you don't slow down. You push through whatever it takes, you keep going, you keep going. And that can obviously work against you. But regardless, kind of coming to a point where you have to accept that I have this pain. It's something that I wake up with every day. I have to live with this. I have to deal with this. I don't know how to. And it's getting in the way of me doing even the normal things that I want to do day to day. It's just the frustration and anger that comes with that, understandably, is along with many other emotions. But we don't talk about feeling angry about having to go through that. And you see that a lot. People are very frustrated that they have been sort of dealt this hand in life. Nobody wants it. There's not a person on earth who thinks one day I'm going to, nobody wants to wake up and live with pain every day. And so, it would be amazing to be able to have this magic wand to fix things, right? But oftentimes that's not how it works. We have to actually come at it quite differently and think about how can we come at this from like a team-based approach. What is this? What's your experience with it? What is your life like? What would you like to see be different? And what are all the things that we might be able to do to get you closer to kind of living the life that you want to live? But it's a complex process for sure, because it's such a complicated experience.
I'm hoping this is the point where you're going to tell us exactly what that process is and what we should be doing about that from a clinical standpoint.
Well, I think that one of the key things, and you mentioned earlier too, the again, people kind of overlooking, I'm going back a little bit, but asking about pain or recognizing the importance of pain. And I know, just to bring it, this is a very serious topic, but, individuals with pain in general are 2 to 4 times more likely to commit suicide in the VA. Over the last 10 plus years, the single biggest factor that is associated with suicide among veterans is pain. Right. It's not depression, it's not PTSD, and I'm not minimizing those things, but I'm just sort of bringing to highlight like the importance of pain and to ask about that and to understand or try to understand as a provider the impact that has on someone's life, and how they feel about themselves, and obviously the way that impacts them emotionally, and their family, and all, everything in their world is just incredibly important. So in terms of the approach, I think the most important thing is really to know that pain is this whole person experience. It's not you can't take a temperature, or there's nothing, it's subjective, right? We don't know, we can't tell. And that's another thing about pain that is I've certainly heard over the years people feeling, when we talked about feeling sort of misunderstood or like, well, you don't look like you're in pain. I mean, sometimes people are experiencing a great deal of pain and they're doing the best they can, but maybe they don't have something on the outside that is as evident, but that doesn't mean that they aren't having that experience inside, right? So I think the most important thing is really asking, and then what does that look like in your life? How does that affect you? What's a typical day like for you? Gives you a lot of information about how much pain impacts someone's life.
Yes.
Are they getting up? Are they getting out? What are they doing? We find a lot of people are really isolated, have withdrawn from family, friends, don't work, don't do the hobbies that they used to do. Again, back to this military group, a lot of things may be physical that they used to enjoy doing, and now they feel like they can't do those things. So really, first of all, just trying to understand what is your experience and what are the different parts of your life that are impacted by pain. And again, sort of it goes both ways, where then pain, not being able to do this or that, is depressing, makes me feel terrible about myself, makes me feel like a burden to my family. I mean, it's just a very difficult process. And you really, ideally, in the VA, we have this option, which is really lovely, having a team of providers who really understand pain and can work with people, sort of focus on different elements, the physical piece, the emotional piece. If there's a medication that can be helpful, of course we want that, right?
Right.
But it's much more complex than that.
And I'm glad you brought up the risk for suicide. And I think just the sense of isolation and having both worked with patients who had chronic pain, and then I unfortunately was on some medications that caused severe chronic pain for a long time. And that I always said, it's funny you said the thermometer. I always wished I had like a little thing on my arm that could actually like truly show, kind of where I was and how I felt. Because it is wanting to kind of keep pushing forward and doing things and not letting the pain completely control me then gets misperceived as, well, look, you're fine. You went for a walk. So clearly, we're walking actually helped my pain in some ways. So it's easy for us to step in it, if you will, as providers, because it's really a hard thing to kind of figure out. And Carin, I was thinking, Carin is one of our sleep experts and teaches CBT for insomnia. And, was thinking how much we learn when we ask somebody to take us through a typical day on the sleep front and some of their habits and things. I think it's equally true with pain. And that's a skill, if you already have it, won't feel so unfamiliar. I think a lot of providers are really nervous to ask about pain because we get anxious to ask about things where we feel like we don't have anything we can do about it, right? And so if they open that door, what's going to come through, and then how are we going to be equipped? But I know that you have worked on and are a developer of the CBT for chronic pain protocol, but maybe you could kind of just give a little snapshot of what do we know are the ingredients that go into a good chronic pain protocol?
Yeah, I mean, there's definitely some core components, right? I mean, one, just you mentioned sleep, and I just have to acknowledge that many veterans many people who have pain, of course, have major sleep problems, right? Falling asleep, staying asleep. So oftentimes sleep is absolutely addressed and mentioned in individuals with pain as something that is a significant interference in their life, is not getting good sleep. So that's certainly one thing that we often talk about. But the core components are really, we want to do one, just some basic education around pain, so that there's this, more understanding. I mean, it's like we're saying about just our culture in general, there's not a real understanding of what is pain, what's chronic pain, what happens in our nervous system, and what expectations maybe are reasonable or not reasonable, what may happen. So we really want to kind of level set with people and talk about what is pain, that it is this whole person experience. And then the really the core components are breathing, relaxation, techniques. But I really think of it at its core. This is really about, breathing, because when we have pain, we're constantly stimulated and aroused on a nervous system level chronically, that is now working against our body and ourselves in every possible way. And so learning to regulate our breathing and activate our parasympathetic nervous system and gain some control over that. And really, a lot of it's about retraining and resetting the nervous system to get us to a place where, frankly, we have more control over our responses to pain, our reactions. Because often what we've sort of naturally happens to people, to everyone, is no longer helpful. And we're kind of stuck in this on mode that is working against us instead of helping us. So we want to sort through that, work through those skills. Movement is also incredibly important. One common thing with pain is it hurts to move, so you stop moving. Totally understandable. However, unfortunately, that leads to deconditioning, putting you more at risk for more pain, more injury, weight gain, things that, again, work against
more pain,
right? And that's a tough one, right? Movement. I mean, when you're in pain, it's not easy, but there's definitely skills around that, like pacing, things that we can do to sort of approach movement in a more thoughtful, safe way. That's incredibly important. And of course, mindset, is the easiest sort of way for me to think about it, but we can get caught up in a lot of negative thoughts. Like, I can't do anything. I hate this. I'm never going to feel better again. If my pain isn't a zero, fill in the blank.
Right.
And so really just trying to increase awareness around the power of our thoughts. And again, there's so much science and research out there supporting these techniques that the more you sort of have these type of ruminating, focused, negative thoughts around pain, the more sensitized your brain is to pain.
Right.
So we can change our brains, neuroplasticity, right? So we can actually do things to make our pain experience, in fact, lessened and better. And so, I think those are like the big, kind of the big pieces, the most important pieces, I would say. And a lot of that, as Carin knows, if you're moving more, if you are doing some of these other things, your sleep also may begin to improve, right? If you can use some of those breathing techniques, or, so hopefully a lot of that stuff starts to come together to improve your quality of life.
Well, that was interesting, because when Jenna said previously, some of us are afraid to ask about pain because we're not skilled in that area, I was nodding emphatically, like, yeah, that's an area that I don't feel skilled in. And so it's not a thing that I ask about very easily or naturally, I should say. And yet, Jen, as you were talking about the protocol, it feels very familiar and accessible. Sure, it's focused on pain, but it is truly just pure, or I shouldn't say that I know this for a fact. I should ask you, am I understanding correctly that it's largely just your standard cognitive behavioral approach of assessment, of psychoeducation, of thinking about that connection between thoughts, feelings, and behaviors, working on new behaviors, addressing problematic cognitions? This seems very familiar all of a sudden.
Absolutely. I think that those underlying principles are so cross-cutting and can help with many different things. It's really about, I think, tailoring it to the person in front of you. I will say, and I think this sort of gets to the why people are scared sometimes, because providers think, well, pain is a medical condition, and therefore, this is something I'm less familiar with. I think using sensitive language is very important. Before, when we were talking, I was thinking about like a real pet peeve of mine, and I would still see this, and this is from providers who I respect very much. And you might see this in a note, or you might hear somebody say, but this person has real pain. And that like makes me like, just like
Like, how
because
are you rating that? How are you rating that? It doesn't even necessarily show up on imaging.
And then do they say
so,
fake pain for the other people? This person has fake pain. This person has
so
real
it's like,
pain,
and
right?
this is the thing. Most of the time, imaging
Isn't
is
true.
not helpful. You know,
Yeah.
I mean, it's like get it, find out, make sure, see what's, whatever. But in many more cases than not, there is no pathoanatomical. It is not the thing that's going to, again, like you were saying, I mean, providers are frustrated. We want answers. I mean, this is our inclination as human beings. I get it. But this sort of feeling of, we need this, the most important thing is like pain is exactly what the person says it is, exactly how they say it is. Their experience is what matters. That's it. I mean, that's what's important, and so many things impact pain, from your learning experiences, your culture, your pain history. I mean, your genetics.
Yeah.
Females, women have some difference. I mean, there are so many things that go into this recipe. And, it's not this easy thing where we can take the temperature, right? It is different for every single person. And so I think as a provider, part of what we talked about as far as ask the question, what does this look like in your life? And then validate, and normalize.
Absolutely.
Like, I understand your frustration. That sounds really hard. I am good with saying, I'm sorry that you have had this experience. Sometimes people share negative experiences in the healthcare system.
Right.
And all you can do is say, I am sorry that you had that experience, And so a lot of it is really just building a rapport in a patient population that can come in a bit defensive,
Absolutely.
feeling like you're not going to believe them. They have to prove, that is one of the things that separate. And I'm saying separates, and that's not even fair. I already said I've worked so much. This is where I've worked my whole life. And of course, many people with pain also have PTSD and other things. But so I don't know if maybe this happens in other settings, but certainly in pain clinics and in specialized pain settings, you do see patients very often. People just feel like they have not been treated fairly or listened to or believed, which is heartbreaking, but you see it over and over.
I was reflecting back as you were talking about that, Jenna, and I used to work in behavioral medicine when I was in the Air Force, and I ran our chronic pain group, and I saw a lot of patients who were struggling with chronic pain, and I felt like the first thing I was doing was trying to help convince them that why they were sent to me was not because somebody thought this was in their head, that there was sort of a reason why behavioral health might have some things to contribute, or sort of undoing some of the negative experiences that had happened to them, and probably really well-intentioned providers, but it just landed on this human who is suffering and frustrated in the wrong way. So it really always makes me happy when there are people that are very passionate about understanding this and helping others to understand and be as compassionate as you would be for somebody who had some other really dramatic, tough medical thing or something that's
Right.
going on. It's a huge identity shift, especially with our military connected population. You go from this identity of being this, able-bodied warrior type to, kind of having these limitations and having to really figure out, what does this look like for me now? And what is my identity now? I know that we talked about our theme this season. I'm just looking at the time, and I want to make sure we get some more things in that we wanted to ask you about. But our theme for this season is sort of impactful moments. So we're trying to really help share these stories that, or things that happened to us or experiences that we had that really sort of shaped our career or how we thought, changed the way we think about somebody that has chronic pain. So, do you have an impactful moment story you would be able to share with our listeners?
Yeah, I think, we touched on it a little bit, but I definitely in the VA seeing a lot of people who have pain and PTSD was very common.
Mm,
Um, and one person who just made a huge impact on me, he was a sergeant major, so Marine, highest NCO, non-commissioned officer in the Marine Corps, and just a lovely person who I started seeing for pain and, focusing on CBT for pain. And he was somebody who really wasn't comfortable going to the PTSD clinic.
mm,
It just he
yeah,
wasn't comfortable with that, and he knew that he had those issues, but he was comfortable coming into the pain clinic, which happens. It's kind of a little advantage you get with pain is sometimes people are more comfortable coming to see you than going to a mental health setting. And so we, just we're not supposed to have favorites, I guess, as providers. He's
just like our
definitely
children,
mine.
right?
And he, we started seeing each other very regularly for CBT for pain, and he started to make a lot of improvements in his functionality in his life, engaging in more, activity. He was a very gregarious guy, but also had withdrawn a lot in what he did. And one of the things that really I learned from that was one, he started to see some benefit with some of his PTSD symptoms. So it's kind of like what we're saying,
Right.
making progress can help be more cross-cutting than
Yeah.
we might imagine, right? But also his experience with me, a positive therapeutic experience,
Mhm.
then led him to be more open to being willing to engage in specialty care for PTSD, which he previously had just been very much not open to. And so then I was able to sort of connect him directly with that, make sure, shepherd that along. And then he was able to make progress in, an evidence-based therapy for PTSD. And just, it was amazing the progress that he made. And I think the reason why it stands out, in addition to just him being such a special person, was that you often get this question, or I have as a CBT for chronic pain trainer and doing different talks over the years of sort of what should you do first?
Right.
Like when people who have co-occurring conditions, like what's the approach? What do you do? And really the answer is like whatever the patient is willing to do,
Yes.
if they'll do anything and one is a lot more severe, then of course you choose that, right? But a lot of times it's not like that, and so it's kind of that no wrong door. If somebody is willing to come to you for something, it's possible that that's going to be this pivotal experience for them that then allows them to engage in treatment that they maybe have been resistant to
Right.
along the way. And just they're I think, again, just experience that took me some time to sort of realize. And again, that's just a question that comes up a lot. And so not only is there just a lot of shared, mutual maintenance that goes on between pain and PTSD, so those certainly can work together in terms of improvement, but also just this idea that, whatever the person is willing to do is a great starting point. And Carin probably sees that with sleep too. It's so important. So start there, and then maybe some more things will follow.
There is such overlap.
I
Yeah.
was going to out Corinne, who did a webinar at one point that was chicken or the egg, and it was, do you start with sleep or PTSD treatment? And we had saw it from both sides, and I think it's really
Mhm.
similar. But I love that story because I think, again, it encourages us to ask the question about pain. We have things we can do about it, and it gives your client options in terms of where do I feel most comfortable starting to engage, and it can lead to other things. Sorry, Carin, I got excited. It looked like you were
No,
about to say
I
something.
got excited too. I mean, yeah, I'm really struck by the overlap. And obviously, we're talking about health behaviors in general, sleep and pain. There is that overlap. There is that connection with so many other conditions and concerns. And of course, poor sleep or high levels of pain have a huge emotional and cognitive impact. So, like, yeah, I feel like everything that you're talking about is so relatable, which perhaps is a natural segue to our actionable intel. Because if you can imagine taking a provider like me who just started out this episode thinking like pain is not something that I necessarily want to work with or something that I have worked with or feel very skilled with. Okay, now you've piqued my interest, Jennifer. You've made me consider whether this is something I should be doing more on. So where would someone like me start? What can I do next to get more proficient in this area?
Incoming actionable intel.
Well, there's certainly a lot of resources out there as far as, CBT for chronic pain specifically. There's also ACT. There's, several other, very evidence-based, evidence-supported options out there. You sort of said already, but a lot of the things that are probably skills that you probably already have in your toolbox are things that can also really help with pain. And so if you're not a pain specialist, even asking the question about if individuals have pain, but then if you can bring that into your session as far as, it helps for this, and also it can help with the parasympathetic nervous system, sort of working against this. You're cranked up all the time, you're tense because of your pain, you're chronically stressed because of chronic pain. And so there are already things that we know how to do that you can incorporate into your actual sessions that you're already doing. The other piece that was mentioned is referring to a behavioral provider who specializes in pain, which can be challenging, but much as like our conversation has gone today, a lot of it is about, there are skills and strategies that we can develop so that you respond to pain in a way that's more helpful to you, that puts you in control. I want to give you some control back. I want to empower you. And, this is a way that we can do this, because a lot of times even physicians or nurse practitioners, they might tell you what to do. This is somebody that can tell you how to do it. Right. So doing more, getting active, being more, doing more movement, things like that. You can say it, but what does that actually look like? Right. So going through pacing, for example, and pacing is this skill that's incredibly important for people with pain so that they don't underdo or overdo, and they can actually start to re-engage with activity in a way that's safe. And that can be a hard sell. Pacing can be tough.
Yeah.
But I always, the phrase I like is we don't sort of rest to do less, we rest to do more. So you don't take a break because you're late. This isn't about being lazy. This isn't about, the non-military. This is to actually be able to do more, right? This is about working smarter. And so just even being able to specifically mention some of the skills and tools and things that people can gain from working with a behavioral health provider, may be convincing enough, to help them. And the other thing, as far as just sort of, and speaks to why I was really drawn to what I'm doing right now, the biggest barriers we have, I think, for behavioral health and changing things, whether you have pain or sleep issues, is engagement in care. So actually choosing care, showing up. And also barriers to access, right? That everybody doesn't have a person available to them that's easy to reach. And so there are some amazing options out there now that are, in the sort of healthcare technology space. Applied VR has this reliever. It's like FDA authorized for pain. And it's so cool because the engagement piece, is this immersive technology where you can actually, find yourself all your senses, are engaged, and it can be done anywhere. So even if you don't have a pain specialist with all of the tools and knowledge, there's a lot of things like that out there now. And of course, apps and other things that can be useful, that can help people with making little changes, which is really where it starts. And it's a lot of great tools out there, which is awesome too.
So I think we will definitely list some of those in our show notes. I will also say for providers who are interested in getting training and in CBT for chronic pain, CDP does offer that as one of our EBPs that we teach multiple
We actually
times
just
a
brought
year.
it back. We brought it
brought it
back.
back. Yeah, dusted it off.
Mhm.
But it's a great way to flex those muscles and get some support. So please definitely check out our upcoming training schedule for that. But I think remember what right? Like we're not coming into chronic pain
Yeah.
with nothing as providers. Even Carin now knows she has these skills. Who knew, Carin?
Even me.
Even
Even
Carin. Even
me.
Carin.
That's pretty good.
That's pretty good. So don't forget what you already know. Kind of put into, I think, remember the context of this client's history to get to your door, and how you may be the first person that listens to them differently than they've been listened to before. And the power of that is really important. And hopefully we can link some tools with VR and with apps as well. But I really feel like just this conversation will help providers in general to maybe move up in their recognition that they are well positioned potentially to do some really good work in this area, and that it is a great population to work with, and that don't be afraid to ask about chronic pain, especially with these high rates of comorbidity with PTSD and checking on suicidality. So hopefully we have piqued your interest, and Carin.
And there's a real need, it sounds
Yes.
like for providers who are willing to do this. Even if they're not full-blown pain specialists, there's a real need for us to be able to ask about it and at least use those skills that we already have to help patients.
So hopefully we've piqued your interest in pain, and we would love to hear reactions if you have any to the episode. Jen, it's been too many years. Let's not make it this long again, but thank you so much for coming back to us and sharing all the wisdom that you have from working in this area of the field for so many years. We feel lucky to have you today.
Thank you so much.
Thank you. Thank you. I am passionate about this area. And like you said, this is a group that often feels helpless, and you have tools that can help. And there are a lot of tools out there that can be helpful to providers and to individuals with pain alike. So yes, I encourage you to explore and find out more about it. It's definitely rewarding. I feel incredibly grateful to work in this area.
Well, Carin, I think that brings us to the end, and you know what that means.
It means we should stay curious
and mind our EBPs.
Yes. Thank you, everybody.
Thanks, everyone.
Be sure to subscribe to Practical for Your Practice to be notified when new episodes arrive. Our theme music is Failed Attempts by Nitro, and our administrative assistant is Bree Mercer. This podcast is produced by CDP at the Uniformed Services University of the Health Sciences. The views expressed are those of the speakers and do not necessarily reflect the opinions of the Uniformed Services University, the Department of War, or the U.S. government. In addition, references to any specific companies, products, processes, or services does not necessarily constitute or imply endorsement by the Uniformed Services University, the Department of War, or the U.S. government.